we will talk a little bit about shoes. So just look at this picture. So there are so many parts in a shoe. So these are things that you might have to advise a patient. Now, say outer sole. You know what the outer sole is? That hard thing. Uh, say the midsole. What is sandwiched between? So, uh, so heel wedges and supports are in not in all the tools. And all these other things that are in uh, uh, in the so this is what is advice for a diabetic with minimum uh, food deformities or with no food deformities. Say if they have a ulcer, they need healing shoes, or if they have severe deformities, they need orthotics. They have a amputated leg, then they need a prosthetic limb. So what is important here, a high and wide toe box. That is something you should advise. And it should have a tough heel counter. See those words that I showed earlier at work. So an outer sole should be tough and light. Right? Ideally, it should be Velcro because it should be easy to put on and put off. Inner surface should be padded to minimize friction injuries. And extra depth, that's a must. That comes in handy when we do uh, customized insoles as well. So this is what you should advise about the toe box. Should be long enough so that the toes don't hit the front end of the shoe. Should be spacious enough so that the toes can wiggle a little, wide enough so as not to pinch the ball of the foot. And it should not be so wide that the foot slides from side to side. Then there will be friction injuries. And it's better to be made of breathable material. And no seams, mahum, and no reinforcements are better. The tongue is the thing that uh, which is under the lace, so it should be padded so that the laces don't dig into the top of the foot. Tushan is here. Okay, let's start. I was just discussing a few things. So I'll
Sorry.
stop sharing. Yeah.
Sorry, apologies
Sashi, we
for.
can start.
Yes, Tusha. I have made you the co-host, so I think you can share.
Thanks, thank you. First of all, sorry for getting late. Got stuck with the work and took some time to sort it out. Let me get this on large. Okay. So the second time we are having a small chat about this. Try and explain a little bit about pressure ulcers, which we're going to talk about. I think principles of dressings and stuff, as you go on, you'll be able to sort those out and understand. We'll talk a little bit about this because it's very common. Anybody in palliative care, involved in wound care, it's a very common problem that we find. We'll talk about as to why it happens. We'll talk a little bit how to manage it. We'll talk a little bit about how to grade it and to see what degree of problems are there. And at the end, we'll see how we can try and prevent it as well, which is more important than trying to heal it. Prevention is the best form of sorting it out. So basically, if you look at what a pressure ulcer is or decubitus ulcer or a pressure sores, call it bed sores, the proper term probably will be decubitus ulcers. That means it is based on long lying on the same place for a long time. So it happens due to prolonged pressure on the skin, and this pressure leads to injury to skin and whatever underlying tissue that is there. Often, the prolonged pressure causes a problem when the skin is pressed against some form of fixed structure. So just because we keep our thigh on the bed, normally we won't be getting pressure ulcers. Why you get a pressure ulcer is often when there's an underlying bone or a joint that doesn't allow the soft tissue to move. So as you press on those soft tissue, therefore you will probably be able to sometimes get a pressure ulcer. So keep in mind, when you see a pressure ulcer, there's probably underlying bone going on. So whatever mechanism of how it happens, there should be a localized problem to skin, underlying tissue, usually over a bony prominence, as a result of pressure. Pressure is often always there. We talk a little bit about the mechanisms, but these pressures can be also different forms of pressure, not the conventional pressure we always only think about, as in putting a fixed static pressure on the same spot. I'll tell a little bit about later on. So again, to reiterate, we normally, the skin has a certain degree of capillary blood pressure. The capillary pressure, if it's or if the external pressure is more than the capillary pressure, or there is some tearing of skin blood vessels, then whatever way it happens, you're going to find that the perfusion of that particular area is going to be compromised. So if the external pressure is more than the capillary pressure, those capillaries are going to get squashed. They are going to get malperfused. If there's malperfusion or poor perfusion, there's going to be cell death. And then there will be ischemia and necrosis. When that happens, you'll find there's going to be a ulceration that's going to happen. So this hemorrhage is something that often happens. I put it there for a reason. Ischemia is also something that happens. So if you look at pressures and how the skin gets damaged, there are in principle 3 different mechanisms they talk about as to how a pressure can be applied on the skin and an injury can happen. What we normally think about, and the only thing we think about often, is pressure as in a direct, constant pressure. If there's a constant pressure on a particular part of the body, it reduces blood supply. That part we know. It's also important to remember there are different mechanisms of forces on the skin. Friction is something that can happen. Friction is when there is rubbing of the skin against something else. It can be the bed, can be the clothing, can be the tissues. If the rubbing happens and friction happens, that also, especially with fragile skin, it becomes very vulnerable and it can get damaged. So things like friction with the bed pampers, the bed pamps, or the bed sheets, or the skin tissue, as you move a patient from a bed to the chair, as you lift the patient up from the chair to the bed. Those little things are enough to cause a vulnerable skin to get damaged. Shear forces are a bit different. Shear forces are when the two surfaces move in opposite directions. The classic example is you keep a patient propped up, elevate one side, or you put Trendelenburg position. What happens? The body is continuously, constantly trying to come down with gravity, but the body is kept up, and that constant friction of opposite directions can cause a shear stress. But it's not too important as to why and why. But remember, there are different mechanisms of force of forming skin pressure. Not only direct pressure, but friction can happen, shear force can happen. These can also lead to skin injury, soft tissue injury, and therefore ulceration. If we have normal sensation, like most of us, like we all have normal sensation, or we are mobile. So even if we feel the pain, if we can move, and we have enough capacity in the mind to understand the pain and to remember and to realize that we must move from that position or change position, we are normally not ever going to get a pressure ulcer. Why somebody gets a pressure ulcer is because either they lack sensation, either they are not mobile enough, or they don't have the mental capacity to understand this. So it's important that you realize that a patient or person who has a pressure ulcer is having abnormality going on. And it is not their fault, but because of these issues, they can't respond to the pressure, and therefore they get a pressure ulcer. Also remember, even with normal skin, we can get this pressure ulcer, but if the skin is more vulnerable, and that is because of fragile skin, thin skin, excess moisture, maceration, contamination with urine, contamination with soiling, with feces, all those things can lead to increased damage risk of the skin. So somebody who is got highly vulnerable skin, somebody who's got abnormal sensation, like for example, diabetic neuropathy people, or stroke patients, or those who have neural dysfunction, paraplegic, those who are immobile, who are not very able to move around, they are weak. For those who are immobile because of their amputations or because they have got a stroke, those who don't have enough mental capacity, these are the kind of people who are going to be at risk of forming pressure ulcers. Whatever happens, once that pressure ulcer is greater than the capillary pressure, you are going to get tissue damage and therefore ulceration. So think of this pathology, think of the pathogenesis, because it's important we try and address those as well. If you're trying to heal the pressure, these are probably the worst kind of wounds to heal. These are extremely difficult, and often it takes a lot of effort from yourself, not the patient per se, but also the people around the patient, the family members, to try and heal these wounds. It's not easy at all. So remember, there are risk factors that will contribute to doing all these things. Unless you try and sort them out, you will not be able to heal this wound. So don't forget things like nutrition, things like sugar control, things like the drugs the patient's on, things like the chemotherapy she's got for various other cancers. Think of those things and try and do what you can to correct those things while you're treating and healing the wound. So there are a lot of at-risk sites, and all these are pressure points because of bony prominences. You look at these pictures, they're very self-explanatory, and you will know that these areas are the ones you often see in people who have pressure ulcers. Now, this is a common thing you remember, but remember, based on how the patient is lying, you'll find different pressure spots. For example, the patient is lying to a side versus lying supine versus lying prone versus lying on a bed or a chair or is propped up. Depending on how the patient lies, you'll find different pressure spots and different at-risk sites. And if you see a patient with a bed sore, then you can also probably figure out how is this patient lying most often in the day. So whatever happens, once you see an ulcer and you know hopefully by now why a pressure ulcer happens, hopefully you will know now what are the risk factors for this to happen. The fact that there is other issues going on apart from simply a wound. And it's totally different to things like diabetes and other things. Whole different set of problems in pressure ulcer patients. But once you see it, you need to decide how you are going to manage it. And to manage it, you need to know how to stratify it into degree of severity. So stage 1, stage 2, stage 3, stage 4 is what we normally have. And it all depends on the layers of skin and soft tissue and subcutaneous tissue it has breached. If you remember how the skin lies, or the epidermis at the topmost cells are dead cells, and you've got a basal layer that keeps on growing new cells. And you have a dermis. Under the dermis is the hypodermis, or the subcutaneous tissue, where you find the fat with your blood vessels. It's a very ischemic area, not very healthy at all. In fact, has very poor blood supply. Underneath that, as you pierce the deep fascia, you find the muscle happening and bones and joints. So if the ulceration depth is limited to the epidermis only, then that's considered a stage 1 ulcer. If it is limited to the epidermis and the dermis, but does not breach the subcutaneous fat, therefore you will not see fat at the base of the wound, it's a stage 2 ulcer. If you're seeing fat at the base of the ulcer, then that has breached the hypodermis, and therefore it's a stage 3 ulcer. Anything going beyond the deep fascia, that could be muscle, bones, joints, is a stage 4 ulcer. So if you look at it, this is why it's important to be able to look at ulcer and try and figure it out. I'm telling the same thing, but in terms of a picture and trying to give some clinical context to it. Stage 1 is that one where we found only the epidermis involved. The dermis is not breached into. It's like a burn. You find erythema, non-blanching, and that's all that is. There is no breach of the skin, no damaged skin. It might be just a little redness that you can see, and that is common for stage 1 ulcers. The stage 2, this one, the green, you can see, it is a lot more than a erythema or blanching. There's an ulceration. It's gone beyond the epidermis, gone deep to the epidermis and involves the dermis. But it does not have the underlying fat that you would see in the hypodermis or the subcutaneous layer. That's a stage 2 ulcer. What is below on the third one is that ulceration has breached the hypodermis and gone to subcutaneous tissue. And therefore, that is why you might see fat and everything else. Right at the bottom, those are tendons, joint capsules, sometimes even bone. There's capsule of the joints, the tendons. Those happen, and those structures are basically under the fascia, and the fascia therefore has been breached. It's a stage 4 ulcer. Now, remember that sometimes you can't exactly say what is going on underneath, and therefore they might be unstageable. They're definitely more than a stage 2, therefore, and we consider they are normally stage 3 or stage 4. Because that eschar, or that hard necrotic scab, or sometimes slug, those are hard slough. Because those are covering the pressure ulcer, you can't exactly say how deep it is. And these are the ones you've got to be really careful about. It could harbor infection, sometimes underlying bones and joints as well. And you have osteomyelitis going and things happening. There's something else that is in the pathology, and it's called the deep tissue pressure injury. And that is when the overlying skin is actually intact. So the skin is normal, but you find there's deeper tissue injury happening underneath. So you will, again, like I said, as pressure builds up, you find the capillaries sometimes getting damaged, they get injured, and it bleeds. When that happens, you find a hematoma formating under that skin, but the epidermis hasn't still been breached. What you don't know is how far deep that tissue injury goes. It hasn't manifested yet. So these are initial injuries that you might see. It's difficult to grade them, but you must be very careful because underneath it could be a much, much deeper wound. It could also sometimes just settle down if you look after carefully, and that hematoma will become hard, solidified, and will gradually just scab off if you're lucky as well. So these are things to be very careful about. Now, just to summarize what we've done so far, remember there are different types of pressures that could cause this happening. It's important to realize it because you got to stop that pressure if you want to heal this ulcer. Don't think of only direct physical pressure. There are shear forces and friction as well. Whatever mechanism, if it's beyond the capillary pressure, is going to deprive blood supply and therefore cause a pressure ulcer. Things like moisture will make it worse, which could be urine, feces, sweat, whatever it is, and all the other internal risk factors the patient has, including mental capacity, poor mobility, lack of sensation, all those risk factors, poor nutrition, low hemoglobin, immunosuppressant agents, chemotherapy agents, diabetes, all those things will contribute. Whatever way it happens, it is our job, therefore, to decide how severe this ulceration is. Stage 1, which is non-blanchable erythema only. Stage 2, when it has breached the epidermis. Stage 3, which is a full thickness injury and gone beyond the subcutaneous tissue. And stage 4, loss of tenderness. Just give me a quick second to answer call this. Remember, there are certain ulcers that you can't grade. They're probably stage 3, stage 4 because they're covered by SCUF. And remember, there's also deep tissue penetration injury. The deep tissue pressure injuries are sometimes safe, sometimes very dangerous. Once you know what is going on, then what you got to do is to try and figure out how you manage these patients. You can sometimes have ulcers with no infection, a clean ulcer, no infection, nothing at all. Or you might have ulcer with infection. Sometimes it's those stage 3, stage 4 deep necrotic tissue ulcers. If it's a clean ulcer, sometimes those early stage ulcer dressings, which are not breaching the skin or just breaching the skin but not the hypodermis, all you got to do is protect with dressings. It doesn't require a lot of care. You got to make sure you control those risk factors, look at all those internal risk factors, see what you can do to the pressure, the shear force, or the friction off, but put a gentle dressing, and those stage 1, stage 2 ulcers will settle on its own. Once you get to stage 3 or stage 4, then you got to start thinking of dressings, thinking of the time concept, think of debridement, think of timing of dressings, think of contamination, think of how you do that, and allow the patient to bathe, allow the patient to pass feces, and how you can make sure those doesn't disturb the dressings. If there's any form of infection, you need to give antibiotics, which can be topical, which can be systemic, based on how your patient is. If the injury keeps on progressing, it's more deep, it's probably sensible to take samples, which could be pus samples, tissue samples. If it is a stage 4 ulcer and not settling, think of underlying osteomyelitis or think of joints arthritis, or sorry, septic arthritis of underlying joints, ankle joint, calcaneum, sacral, iliac joints, all those joints can get involved as well. If you think there's a necrotic scab and you are worried that it can be harboring infection inside, those unstageable pressure ulcers, especially if you press and there's some bogginess, you might want to debride those necrotic scab and see what is going on underneath. Again, you got to be careful about it because a scab is often a very safe thing. It's the best dressing you can keep for a patient. But if you're worried underlying there can be infection, then you probably have to remove it with sharp debridement. Principles of wound dressings, I'm sure you have been talked about. Moist wound dressings. Create the moist wound bed environment that will allow moist wound healing. So remember that no matter how much you try and prevent this from happening as well. So the prevention has to happen while you're caring for the wound as well. It includes making sure you minimize further pressure, shear, etc., which could be by making sure you have a air mattress or a water mattress. Think of having pressure charts, turning charts, So you can keep on changing. Document all your findings so that you know when somebody else comes and see the patient, know what was stage 2, stage 4, etc. Manage the moisture and manage the skin quality, which could be moisturizing creams, powder, making sure the contamination doesn't happen, having pamper off times, for example, have time without any pampers. Make sure the hydration is good. Make sure your albumin and hemoglobins are decently paired. If you think your patient is at risk, and that is how you try and prevent these people, continue to conduct regular skin and risk assessment to make sure that these ulcers are not going to happen. The best thing you can do. So I hope that was okay. I hope that I got some information on what I need to tell. I'm sure these are stuff that you guys all know, but I'm trying to add some knowledge and some science, a little bit about some principles, so that you can think of these in looking for your patients. Thanks. I think that's probably the end of my slide. Again, I don't want to be too comprehensive and bore you all with information, but I hope that was there's some education to think about. So thank you very much. If anybody wants to ask some questions, please, that is fine. I'm more than happy to answer any questions you all want. But otherwise, I'll hand things back to Tusit and Sashi to continue. Stop sharing.
Thank you, Tushan. I mean, agreeing to do this lecture at this hour. I mean, I know you are really busy. So thank you very much again. Any questions from the audience?
That's fine. So,
At GP level, up to what stage we can handle?
I don't think there is any I don't think your level of training in terms of whether you're a medical officer or a consultant or a GP is very important. I think if you have the adequate knowledge, it's something anybody can manage. What you might struggle is if you need to start IV antibiotics, or you need to start any debridements. If you want to think of sometimes doing diversions for urine or for feces, those sort of things become a bit difficult to do as a GP. But in terms of the basic principles of choosing, of identifying ulcer, trying to use moist wound dressings, trying to use a time sensitive with the right dressings, prevention, take the pressure off, those sort of things are common that anybody can do. If you're unsure, maybe stage 4 dressing, so stage 4 ulcers might be a little bit difficult to manage, but I think if you continue to work in these courses, you see more patients, you keep on doing, it's more of a confidence that you require to manage these wounds. Because I promise you, even consultants won't look at these very carefully or with a lot of interest. So I think non-consultants probably look after these wounds a lot better than surgeons and consultants. That's my honest opinion. Tusam, you can add to that as well if you want, but any spray. Yeah, I think one important thing about this pressure ulcers is looking after the skin, what you call the peri-ulcer skin or the peri-wound skin. It's often at risk of maceration. So when there's maceration, that skin continues to get damaged, and therefore the wound keeps on getting worse. A lot of these sprays in the market, they are helpful because they have a little barrier cream effect or a barrier effect on the skin. So it doesn't allow the maceration to damage the peri-ulcer skin, with its zinc oxide based or sometimes with a bit of kaolin. There are different brands available in the market. Some of them combine those barrier cream agents with antibiotic included impregnators, so like chlorhexidine maybe or sealer maybe. So you can use them, and I think they're often very helpful because it's easy to apply. What you'll find is even if you have a decent, let's say a foam dressing or a seal dressing, it's difficult to keep it positioned on the ulcer, on the pressure ulcer. You don't want to be applying a lot of plasters and stuff on it because the plaster sometimes can cause skin damage. So these sprays are sometimes useful because you don't need to have a lot of additional secondary layers on it. You can spray it, you can put a towel or something and use that as a dressing rather than trying to put plasters and adhesive dressings on it. What about applying Gentian violet for stage 1? That's fine. And I think those just need a little bit of care and love. And to take the pressure off it, stage 1 will heal without any problem at all because the epithelium hasn't been breached yet. So all you got to do is put a little padding, maybe take the pressure off it, advise a patient, and often those will settle down. Place of antibiotic spray in bed sores. Yeah, again, I think if you think there's cellulitis going on, some particular infection, and if it's local infection, the chart, I can share the chart later if you want as well. If there's local infection, you can use local antibiotics or local antiseptics. So often we can use a dressing that has those antibiotic or antimicrobial activity. So often these sprays and these drugs and these foam products, they have some antibiotics. And the place of using that is if you think there is local infection. There are some ulcers which are clean with no infection. They don't bother about putting antibiotics because it might cause resistance. Yeah,
I think they were asking about, sorry to,
sorry.
The place of antibiotic spray in the sense, I think they are asking about this multi-sole type of things. No, yeah. What do you think about that?
I don't want to mention names. There are a few in the market.
So, say, let's say multiple antibiotic containing topical sprays.
Yeah. I think
those are not targeted therapies.
Yeah, I think antimicrobials are often safe to use. That is fine. There are antiseptic sort of impregnant things which are often fine. Anybody who wants to use antibiotic into a wound, whether it is pressure ulcers or otherwise, you got to be careful. One, they might not be as effective as you think they are, and secondary, often if you think there's infections, always best to get a sample culture and give a targeted antibiotic for what you want to give. I like those sprays purely for their ability to have a barrier effect, which I find very useful, especially for pressure ulcers, and because of the ease of applying. Often I feel it's impossible for some healthcare worker to look after these dressings all the time, the pressure ulcer, because it often gets soiled sometimes twice a day, sometimes daily. So the patient, or the family or the carer has to sometimes use a dressing agent, and the spray is probably easiest for them to use. So for that reasons, Atush might agree or disagree. I find the spray useful, but I wouldn't really spend the antibiotic on it as what is the most crucial thing there. That's my personal opinion. I mean, but you might disagree. I think I don't know. You disagree? Agree?
Yeah, I will never use antibiotic sprays on bed sores. I mean, there's an infection, you treat it with antibiotics. I mean, it's their local or otherwise cellulitis or sepsis. Other than that, it's just wound bed preparation, and I mean, these are. My observation is that these wounds are quite closer to heart. If you sort out the wound bed, the wound will sort itself out. Where there's enough vascular supply, if we correct the nutrition, the hemoglobins, and if necessary micronutrients, and to take off the pressure, these will heal. Just need a little bit of gel. So sometimes we might need a little bit of say some addition of something like Metrogel or some anaerobic this thing to take off the smell though. But that is also, I mean, if you have done the wound bed properly, that will go off just a matter of time.
Yeah, I think have you done the wound dressing topic?
Yes, we have.
So I think if you're going through time concept, that must have been taught. So I think whether you want to use a gel, it's all about getting the right moisture balance for that wound. But like to say, so if you want to have moisture in the wound, then use appropriate dressing. If there's too much moisture, you want to use something that, so moisture balance and all those things are part of any wound care. Um, uh, and you choose what is most appropriate for your patient, based on the requirement. Um, but I totally agree. Antibiotics are not something we use topically, especially blindly. Antimicrobial stuff is okay because they don't cause resistance, but you got to make sure that the wound actually needs it. Even in that chart, and you remember that left side, we have pressure ulcer clean. That does not require any antibiotic of any sort, not even antiseptics. Um,
Yeah. So, can you post the link
we
of the
have to remove
advanced
the
wound care
hard.
course you mentioned in the last lecture?
Tusita can do it.
Yeah,
I'm sure
we
Tusita,
will be
we can.
posting. Yeah, yeah. If you follow the
Okay.
Persevere website, and of course the whatever the materials we provide in Persevere as well, and it will be posted in my this thing. I'll be copying the Persevere thing, of course, and we can post it here in the WhatsApp group. So just
Yeah, sure. This is
yeah, just have an eye on that. Uh,
any
so
comment. And we have to
another
remove the
one.
hard stuff before.
Any
Uh,
commercial available preparation in the sense, I think, about the sprays, no? So
yeah,
we will be
I
talking
used
about these
to,
things here. Yeah.
yeah, I used to like certain dressings were there which were adhesive dressings. So you could actually avoid using plasters, and the dressing has adhesive border to it, and you can use them. And there were certain products those days that were shaped for sacral ulcers, shaped for heel ulcers. We don't have them anymore now. But when they were there, sometime back, they were useful. Now, of course, I think you don't need to spend that amount of money on these things. This is a very long process sometimes. I think what is important is to train the carer, uh, to make sure you do all the right things, and use what you can, simple stuff, to get the right wound bed sorted out and the dressings sorted out, and the wound will heal on its own. Uh, because I think this is not easy. A lot of money will be required. I don't want to spend a lot of money on this also.
Do
Simple
we
things.
have to remove the hard? Yes. Do we have to remove the hard slough before the dressing? I think they're talking about what is
I keep my personal.
deeply attached.
Um, so I think from my point of view, if it is a clean-ish wound, if there's a eschar or a hard scab, that's probably the best dressing you can have. It's as good as normal skin sometimes. It's a good barrier. Bugs don't go. It helps the moisture to keep maintained. It has a lot of benefit in keeping it. If you remove that hard scab, then you'll have to have underlying tissues exposed, soft tissue, moisture balancing, exudate, underlying structures to look after. All those things have to happen. So if you can keep it, which is fine, if it's very dry and there's nothing is going on. But the bodies, most of these ulcers, sometimes there is underlying infection going on, and it is not apparent until you remove that hard slough. What I call it, uh, ungradable pressure ulcer, which has often stage 3, stage 4, and those are very dangerous, especially if there's a bit of bogginess underneath. If you press it and there's softness, bogginess around the skin, around that ulcer, and the normal skin is a bit inflamed, erythema. Those I would definitely remove that hard slough or the eschar and see what is going on, clean it, and then do what I want to do. But if I can keep a hard eschar or hard slough and the wound is clean, there is no discharge, no smell, patient is otherwise okay, there is no warmth, then I might be tempted to leave it alone. Suchita, you agree? Disagree?
Yeah. I mean, my take is that, say, hard slough. Now we will be dressing this as if the sacral wound is there. We will be dressing them very frequently whenever they are being soiled. So I would not actually bother pulling them off and causing any trouble to the patient or pain. So eventually it will come off with moisture. So the enzymes will act on and say, I mean, uh, each time you dress, you can just pull on the slough. Whatever comes out will come out. If it's clean, as Sushant said, you don't have to actually bother. You just keep it. And dry scab is the best dressing we can have in such situations, such dire situations where we don't have much options. So sometimes we can make this what is called hard slough a dry scab, so that will act as a good dressing. So, anything to add, Sushant?
No, I think what you told is perfectly fine. Sorry, give me a second.
So I think it's same for the say the underlying tendon is involved. Is it always necessary to remove it? What do you think?
If underlying tendon is um sometimes you can't remove all the tendons. It's impossible to remove everything that you see that are not viable or not tendon tissue. Most of them, especially sacral sores, you probably might not be able to do it. If it's a calcaneum or something, and that of course you can remove. I think if it is remove, if there is infection going on, you're worried that tendon is going to track infection through the tendon to the other places, then you might want to remove it. But often in pressure ulcers, it is not so straightforward. You can't remove all this stuff. There's fascia, there's capsule. If you remove that, then the joint gets exposed. So a little careful. If you look after carefully, if you don't damage that's what's called, there's a little very sort of like a little fascia over the tendon. If you leave that fascia over the tendon, it will granulate on top. If you debride or you scrape it or you remove that little fascial covering of the tendon, then that tendon will probably start to become necrosed and dry and then can get infected. So any of those tendons, if you can leave that peritoneum um, intact, it might actually granulate on top. And for pressure ulcers, you can actually try it and see. But if that is breached, it is necrosed, there's infection happening, you're worried there's pus coming along these tendon tracts, and by removing it, you're not going to cause no irreversible damage, then of course you might not remove it. Tushita, I might have to go off for a little bit.
Yeah, sure. Thank you very much. And yeah,
Thank
we'll
you
answer
for all these
the
questions. Thank you
questions.
very much for asking questions. Always useful to ask questions, and we also try and discuss things. Right. So thank you. I'll excuse myself for a tiny bit. I'm Tushita and Sashi will take off. Thanks, Tushita. Thank you again. Thanks, Sashi.
Yeah, thank you so much.
Sushant. Thank you.
Thank you.
So, yeah, to answer, the last question, how to manage stage 4 pressure ulcers on the buttocks with pelvic bone osteomyelitis. If you can take off the osteomyelitic bone, that's fine. Otherwise, it's an expectant management. It depends on the what we call the surprise question. Whether would you be surprised if this patient dies in 3 days? So if you are not surprised, I mean, don't do anything much. Just maintain the wound. If you are so surprised, if he dies in say 6 months, of course go on full blown and say, try to heal it. Say if you can nibble off osteomyelitic bone, if we can undergo some anesthesia, that's fine. If if the patient can't feel it, you can do it in the bedside, of course, with if the hemoglobin and everything permits. Then just apply some gel and take off the pressure from that area. It will heal. So that's my experience. So any questions on that as well? And say practical session will be held on 16th. Sashi, would you elaborate on that on about 16th? Yeah.
Yes. So the sessions will be at the Sir John Kotalawala Defence University Hospital, and it will be on the 4th floor, next to the auditorium. And we'll be starting at 9 and hoping to finish by 12:30. And refreshments will be provided for those participants. And we hope that the assignment, maybe we can collect it after a week after the practical session, after the 16th. Tustu, what do you think? So we'll fix the deadline 1 week after the 16th. And I know there are a few people who are having difficulties on attending on the 16th. So we will try to make some other arrangements for you. Maybe in this clinic or somewhere where you can get the same hands-on training as well. So what do you think?
Sorry, I was away for a while. So yeah. Moment, please. Hope everybody can see the thing. Is it visible? The slide is the slide visible?
Yeah, we can see the slides.
Okay, thank you. So yeah, this will be the last lecture for the day. Dr. Kirti and Dr. Hillary, they were hip deep in work. We will try to arrange. I mean, they will be leaving the country very soon as well. So we'll be arranging those lectures later. But I want to talk about that as well in the wound prevention. The topics will be covered. The only thing I couldn't get got some slides prepared for some of the topics, but now my original lecture is here, so we'll be talking a little bit about the ostomy care as well as urinary the incontinence as well. So moving on, say now to talk about prevention, say the prevention should be practical And if you do not incorporate prevention in your practice, as I said in an earlier occasion, I think no, there was some other group. So anyway, if you don't have prevention in your menu, you are not actually doing wound care. So it's a must. You should incorporate preventive aspects into your practice. So, I mean, in primary care, prevention can be primordial. I mean, you prevent from the patient from ever getting a wound or the wound causing things, the diabetes, accidents, or whatever. So it's sometimes it's practical, sometimes it's not. So can be primary, secondary, tertiary. So I mean that's not the scope of this lecture. So what we do is actually prevention of all levels, all four levels: primordial, primary, secondary, and tertiary. And then prompt referral if there's any problem. And then we do follow up, and we do health education and health promotion. So primordial prevention, the health habits, the exercise, high activity level, all those things, avoiding alcohol, tobacco, weight to high to waist ratios, and all those things are applicable to wound prevention and amputation prevention as well. So primary prevention is, say, foot care, footwear, health education. There are preventive surgeries for foot as well. It's not happening in Sri Lanka. But say bed sore prevention and stomach care, urinary continence care, and all those things. So I'll skip. So these are the things that we talk about in wound prevention. Skin care, good commodity control, of course. Hydration and nutrition is very important. Foot care, footwear. So we'll go into details very soon. And ostomy care, continence care. So about foot care. So you will be asked to not you'll be asked to, but you will be expected to provide some foot care advices to your own patients. How to check feet, how to cut the nails, how to and when to do moisturizing, and about footwear, of course. So checking the feet, I have a proposed model of 5 steps. So you can go to my YouTube and it's there. So it's Dr. Kahadu at youtube.com. It's there are foot care advices. So this is the model. So this is how you advise. First, the preparation. You have to advise them to dedicate a fixed time every day for foot examination and to have a diary. And wash and clean the feet with lukewarm water, and the warmth should be checked with the hands because hands are affected less. The neuropathy affects hands less. So they have to choose a well-lit place or use a lamp. If you can't examine your feet on your own, use a mirror or ask for help. That is quite obvious. So every day this should happen. So what you should advise them to look for is, say, I divide the foot into 5 parts. So first, I would advise them to examine the hind foot, mid foot, then forefoot, and then the toe webs, the nails, and the toes, and the dorsal. So what we have to look for in the, say, hind foot, midfoot, and forefoot will be cracks, blisters, uh, any other damages, and of course, you have to ask them to compare the temperature in each part with the corresponding part of the other foot. So if there's a change, if one is cold or one is hot, that is alarming. So in the toe webs, you should look for these fungal infection cracks, any holes that will lead to the joints, like sinuses, any discharge, that sort of thing. And the nails, of course, they have to push a little bit on the nails, see whether there's any drainage or, oozing or anything, pus, fungal infections, and that sort of thing. So, yeah, the dorsum also, any cuts and, say, shoe cuts or that sort of thing. So, it's the same thing. Then, if a patient asks you how to cut the nails, so just cut them across. Ask them to cut them across, and the nail is there to protect the toe. So there should be adequate nail left to protect the toe. So that's why we leave a little bit until the toe is covered. So not ask them not to use this raft that is provided and make the edges round. Just cut it across. And moisturizing cream, they should apply at least twice daily from the metatarsal head areas to over the calf till the knee, but not in the toe webs. The toe webs, you put powder. And this is something that I would like you all to know. So, because we are going to talk about shoes. So there's this concept of the kinetic chain. So whatever you do to the foot will give rise to engagement of other joints to keep the head straight. So all the other joints will go berserk and keep the head straight. So if you elevate one foot, say if you deform one foot, then the correction will go from ankle to knee joint to hip to the lumbar, thoracic, and all those spines, as well as to the cervical spine, and he or she might end up with osteoporosis of those joints, or constant chronic pain, or even headache. And we'll skip that. That's what I was talking about. So now to talk about footwear. Now you will be expected by the patients to advise them on footwear as well. So we talk why we need special shoes in diabetics is that because they have neuropathy, they can't feel their feet, and there are foot deformities because of the neuropathy and say previous infections, amputations, and all those things. And there will be eventual fat pad migration, causing just the skin and the bone, transmitting the body weight to the ground. So causing, pressure points with which can damage very easily. So wounds means in diabetics, wounds mean amputation. So further to the healing shoes can actually be healing. Now see this one. Now we were talking about dry scab as a dressing. So we have used this. I mean, these are real life patients. We have used this dry scab as a dressing, and we have just put him on protective shoes, offloading shoes, and the wound healed quite nicely. Nothing much done except for the shoes. So you saw this. I'm not going to waste time on this. So just remember, you should have a high and wide toe box. This is very important. That's why now these are things that we are going to advise. High and wide toe box, tough heel counter, tough and lightweight outer soles, Velcro or adjustables, good padded inner surface, extra depth in the insole. So these things, and I will just talk about a little bit about the insoles. So there will be custom insoles. Some of your patients will be having custom insoles. So just note that those inserts will have at least 3 layers and a soft layer of foam in the top. So, and there are various types of soles, rocker bottom sole, and all those things. So, this is what you should advise your patients what not to buy. No high heel shoes, they increase shear and the movement of foot tissues in opposite directions. So shear is the primary cause of calluses, blisters, and ulcers. So no high heel shoes and no slip-on loafers. Bata, I guess nobody from the Bata company is here. So this national shoe, as for Professor Mandika, he calls them national shoes. So no slip-on loafers. Say that because it's not covering, not protective, and typically made of unpadded rigid leather, rigid rubber actually. This can be a source of friction. And sandals that have straps between the toes. Sandals are good, but not with straps in between the toes. And the shoe size, most people get it wrong. If you're a diabetic, you should not go for the upsize. You should have the correct size. You should measure. I mean, there's an instrument in the shoe so the shoe shop. They are supposed to have an instrument to measure and get the correct size and use the instrument and ask them to choose the proper size for you. And there should always be a test run. Put it on with the socks or whatever the way you are, the patient is going to wear daily, and then walk around the store and see whether it fits and if there is causing pain or whatever. Remove and see whether there are red areas that have been having shear stress. So. So far, any questions or any unclear things? So now to talk about bed sores. Now, Tushan, I think, spoke about these things a lot. So just remember this picture. there are very uncommon places that you might get, like the back of the head, shoulder blades, elbows, ear, side of the head. And even when the patient is sitting, now we make them sit, thinking that it's going to be better than lying supine or whatever. So it's then also you will get these things. So there are a few questions I'll answer later. So, so just remember this. So preventing bed sores is about looking, and looking. So first thing is look whether there's a risk assessment. Upon admission or within 8 hours, everybody should be assessed. These are inpatients. So if you are called for a say home visit, you go and do this, and then ask the caretaker to do it daily. Or if there's a change in the patient's general condition. So skin assessment. So skin turgor, moisture, edema, redness, and especially around and underneath the medical devices. That should be done every 12 hours. Then you will pick them early, so there won't be an ulcer. Skin care, something that we have to talk about. So barrier products, can use zinc oxide paste. Now there are Coloplast plus paste and all that, expensive stuff, and cheap stuff like zinc. So keep the skin clean and at normal moisture, not too much. Clean the skin with a pH stabilizing product. That's actually quite expensive to do those things here. Say lukewarm water and then dry it. And do not rub strongly on the skin. And do not massage. I mean, massaging is okay, but not say rubbing type of massage. Just push and push and release. That sort of massaging is okay. Not rubbing and pulling. The sheet should be kept clean and stretched and dry, no lines. That is bed linen. So, nutrition. So, if the patient is bedbound and debilitated, the caretaker must be given nutritional goals. These people are very difficult to be fed. So, a dietitian, or I mean, you yourself, if you have some experience, you can advise. So, if it's necessary, provide special nutrition. They have to they have to be given daily goals, and if necessary, you can follow up with albumin and CRP levels weekly. And the state of dehydration should be evaluated at least twice or thrice daily and corrected. So, activity management. Oh, they should be, say, 2 hours in bed, 1 hour in chair. So can be positioned at 30-degree angles, and all those things can be done. But remembering that all these positions can also give rise to various pressure points. So you can elevate the heels of surfaces using pillows, and you should never advise them to position at 90-degree angle. Do not position directly on the area of redness if you have noticed such. Not position directly on medical device. you should have a air mattress or at least a normal mattress, something to cushion. So most important, moisture and continence management. So some barrier product after every episode of urinary incontinence. Most of these people are urinary incontinent. So just check whether there is an indication for a catheter. So whether it should be an indwelling catheter, indwelling silicone coated catheter, or silicone catheter. So if you don't expect this say the wound to heal with this incontinence, the urinary incontinence, if it's really bothering the wound healing process, you can go for a catheter. I mean, condom catheters are actually better in the sense they are not invasive, but the problem is they will give rise to skin damage and various other problems. Tend to leak as well. So it depending on the case, you can decide whether to divert into a sort of catheter, or whether, I mean, extreme cases, whether a diversion is needed if, say, you are treating a cancer patient with urinary and fecal incontinence through various abnormal orifices. So whether you should go for a urinary diversion. So those things have to be thought about. So again, fecal incontinence, another problem. If the wound is huge, maybe it's better to get a loop colostomy or an ileostomy. So later on you can correct it. It all depends on actually the surprise question I told you all earlier, whether the patient is, whether you will be surprised if the patient dies in 3 months or 6 months, whether it's worth doing this horrendous procedure. So other thing is, say if the all these moisture and contaminants are bothering the wound healing process, diapers are making it worse. So you can avoid using diapers. Just put them on a clean red linen, cover with a blanket, and when he passes, you can remove the thing. It's much drier. So you should always try to minimize skin contact with urine and feces. Avoid excessive skin moisture, that is the thing. So support surface management. So if the patient is totally bedbound, should be put onto a better support surface, that is a air mattress. Air mattresses are better than water mattresses. So the support surface, the air mattress, should actually work. It should some one row of bubbles should go down, one row should come up. So that's how it works. And it should be set usually the regulator should be set to the middle. Depending on the weight of the patient, you can decide that. I mean, once it's totally inflated, the patient should be on those bubbles, not otherwise. And there's a way that you should set it up, and time to time the caretaker should be advised to check for leaks. And whenever you come across a patient with a recurrent pressure ulcer, and that has been put onto a air mattress earlier, it can jolly well be a leak. It's the bubbles are apparently blowing up, but it doesn't hold enough pressure to keep the patient on them. So skip that. So look. So the stomas, actually what we come across are ileostomies and colostomies. So they can be loop or end. So what stoma care, the basics are, say, gentle regular cleaning of the stoma and surrounding skin using lukewarm water and a soft cloth, and followed by drying. So appliance bag should be cut out 2 to 3 centimeters larger than the stoma to prevent skin damage. So monitor for potential complications like skin issues like redness, breakdowns, and blockages, infection, and you can have stoma herniations and all those things. I think you all know those. And can be edematous, and say even the part can be necrotic and slip off. So on those occasions you have to notice these and refer to the surgeon. So, and ask the caretakers to empty the bag when it's about 1/3 full, and ensure good hand hygiene after these procedures. So there's another one for wound prevention. It's also available in my YouTube. So in summary, we spoke about spoke about the what we can do in the primary setting, foot care, how to choose footwear, and bed sore prevention, as well as a little bit about stoma care and incontinence management. So I would stop here. Are there any questions on this? Yeah, there are a few. So, these shoes are available in usual shops? Well, there is the problem of now say what is available is these two brands, the Nirogi and Beta. Beta is a copy of Nirogi that is available in DSI. Nirogi, I mean, both of those designs are by me. But the problem was that was the prototype 3 that they took for production. We should have gone another prototype. Had we gone another prototype, we would have given the proper ankle support. So there are no ankle support in these any of these products. So these are not the ideal shoes. If you come to this, somebody wants to ask question. So now we have we have gone through prototype 4 and 5 both. Now we actually have the pre-production prototype 6. You can see those if you come to our clinic every Wednesday in Colombo Medical Faculty, 13th floor, from 9:30 to 2:30. So I mean, these are still pre-production test things. So those are actual healing shoes and diabetic shoes with what we discussed. I mean, we are trying to get to the sort of ideal and ideal for our patients. So those will be available very soon. Not in DSI, but surely in shoe shops. For the time being, of course, there are no other option than Nirogi. So So, can we custom make a shoe with 2 bars stick together and make a hole in the upper backs corresponding to the wound? I don't understand what bars stick and upper backs. I don't understand what he means. I guess, say, what he's asking is about, say, a deeper insole and make a hole. So, my experience with foot mechanics and wounds is that this whole business doesn't work. I mean, it's nowhere in. I mean, I have not seen any say shoe. Uh, say any shoe research or whatever discussing about the holes. So it's about metatarsal bars, say midfoot elevations, arch supports, and say rockers, and those things are the scientific things to do. So you can actually observe what we do these things. I mean, we take the pressure points and then we correct them with using that science in our clinic. So no holes, elevation works. Can a patient be? I will show you all how a metatarsal bar is done and all that, and actually you can do it at bedside, even without a shoe. And a midfoot, say arch support and all those things, we can do it with bedside. Don't need much. Can a patient be placed in an air mattress for a long time without changing position? Yeah, it depends on the where the risk area is. Say if the patient doesn't have any currently threatened area and the patient is well fed, and if he or she still has uh, the fat layer, you can leave them without changing. But if it's a very thin, debilitated, with sort of skin and bone sort of patient, better to use some other stuff as well and then change a little bit and say try to stretch them a little bit, change the position, so that will help. And even they are on a air mattress, they can get a bit of a shear injury. Are there any questions? Any other questions? Anything about stoma and incontinence? So, in the absence of questions, can we call it a day then? So, I mean, this is the last lecture. It's a privilege to be the last person to speak to you all. Shall we finish then? Shashi, what do you think?
Yeah, I think we can round up. I think we have covered all the
Yeah,
topics that we
yeah,
planned initially. So the one that's be done by Dr. Kirti will be an additional session. So we will see how we can arrange it for you. So that with this session, I think we are officially completing the online session. So we are hoping to see you on the 16th for the hands-on session. So we
yeah.
will be updating you on the registration in the WhatsApp group. So please go through, and if you have any questions on the assignments as well as any issues with the participating for the hands-on session, please post on the WhatsApp group. we will see how we can accommodate it.
Yeah,
And your
and
set,
yeah,
yeah,
good
and
luck.
your certificate with the CPD points, we will we'll give it to you once we receive your assignment.
So
Yeah.
good luck, and quite a silent group. I mean, we have had lots of discussions in the first and second one. So I would, like if you spoke a little bit more. Anyway, so best of luck, and please continue the interest in wound care. And so if there are any problem, we are always available on WhatsApp. If someone of you call me, if I didn't answer, I will call back. So my number is here. If you have any wound related problems, you can call me at any time. So WhatsApp would be easier, but I would be checking once, maybe twice a day. So you can call, no problem. You can call at any time. So again, best of luck. If somebody cannot participate on 16th session, you are most welcome to come to my clinic, and I will do the same teachings that we did in the 16th session, and you can do some dressings. If possible, do a callosity excision as well. Let's see how it goes. So thank you very much, Shashi.
Yeah, I think with that we
Wind
will
up.
wind up. Yeah. Thank you, Tusita, for doing the lecture, and we think we'll thank Dr. Tushan as well, even though he's not here. I mean, he was very busy, but he was gracious enough to participate and contribute for the session. And thank you all for joining, and thank you very much, and have a good night.
Thank you.
Thank you very much.